Hello and welcome to Chapter 12, the primary assessment for the EMT. So we're going to look at the second phase in the assessment section. The first phase was scene size up, where we determined our scene safety. We donned our BSI. We um, determined whether we had a mechanism of injury or the nature of illness, basically why they called 911, and how many patients we had, and if we needed any additional resources. In this one, we're going to look at the primary assessment and how all of that kind of follows. Okay, so our approach to this is we're going to focus on life threats. So that's the airway, breathing, and circulation. Again, I've told you numerous times that it doesn't matter what happens to that patient, but if you don't have airway, breathing, or circulation, you can't fix anything else. So you've got to fix those things first, and that's why they're in the primary assessment. Okay, so this can also vary depending on the patient's condition, how many EMTs you have on scene, and any kind of other priorities that may come about as you assess your patient. So the order of ABC depends on the initial impression of the patient. The sequence can vary. You can do ABC, airway, breathing, and circulation, if the patient has signs of life. And then we're going to switch over to the CAB if the patient appears lifeless with no pulse. So CAB is our BLS guidelines for CPR. So circulation, airway, and breathing is how that goes. And then it's also going to vary depending on what kind of interventions may be needed. We may need to fix the breathing first, or fix the airway first, or anything like that. So we just need to be aware of those things. So decision making in the primary assessment. So any vomit in the airway that enters the lungs is very serious and can be fatal, causing aspiration. Exsanguinating bleeding. This is serious bleeding, causing basically the patient to bleed out. It has to be stopped immediately, and breathing and circulation are absolutely vital to life. Okay, breathing goes in and out. Air goes in and out. Blood goes round and round. Any deviation is a bad thing. So if immediate interventions such as bleeding control or CPR are not required, then we're going to shift into an important but less urgent mode, which is where you'll administer oxygen that's appropriate for the patient's condition and evaluate for shock. Okay, so this is our kind of checklist for the primary assessment. So we're going to form a general impression. We're going to assess the mental status. We're going to assess airway, assess breathing, assess circulation, and then we're going to determine the patient's priority. Are they priority 1, 2, 3? Do they need to be transported now? Or, is it a load and go, or is it a stay and play type patient? Okay, so the general impression, this assesses the environment, the patient's chief complaint, and the appearance. It helps to determine the patient's severity and helps set priorities for care and transport. This is done within 30 to 40 seconds of meeting your patient. Okay, you can get your general impression of the patient. Basically, what you're looking for is this patient sick or not sick? You're going to look at where the patient is. Are they at home? Are they sitting in a chair? Are they laying on the floor? Are they laying in bed? What is around their patient? And then the patient's chief complaint goes into this, and we're going to look at what are they complaining of? Was it a fall? Was it, is it chest pain? Is it abdominal pain? Is it strokes? What was their chief complaint? And then their appearance. So their appearance is what we're looking at for how well do they look? Do they look sick? Do they look okay? Are they pale? Are they diaphoretic? Are they in obvious distress? All of those things go into our general impression. Okay, and again, this helps determine our patient's severity, and it helps set priorities for care and transport. So the look test, feeling from environmental observations as well as the first look at the patient. This is one of those things that I just said about. Look at where your patient is. Are they sitting? Are they laying down? Where are they? Okay. So with this patient, our general impression is that she's probably scared. She's 7, 8 years old. Appears to be distressed. She has the cloth over here with blood soaking. She's got an injury to her forehead as well. So, with this, our general impression is probably a fairly good one. She doesn't look to be in too much distress. Okay. So the point of the general impression is to kind of figure out which patients may be critical. Okay. So to do that, we're going to look at patients who appear lifeless, and resuscitation by beginning CPR compressions, and using the AED as soon as possible. Also, patients who have an altered mental status, and patients who appear unusually. Sorry, my face is in the way. Who? Hold on. All right. So sorry. Patients who appear unusually anxious, and those who appear pale and sweaty as well. Okay. Obvious trauma to the head, chest, abdomen, or pelvis. Specific positions indicating distress. Tripod position usually indicates difficulty breathing. Levine sign is chest pain or discomfort. Levine sign is just that clutched fist at the chest. So the chief complaint, the patient's description of why EMS was called. This may be specific. They may say, well, I have abdominal pain. Or they may be vague and say, I'm not feeling good. So you then have to go into why they don't feel good and have to determine what exactly their problem is. So forming an impression of the patient. So we're going to look at the patient's age, sex, and position. We're going to listen for moaning, snoring, or gurgling respirations, and then we're going to smell hazardous fumes, urine, feces, and or decay. Okay. You can smell. EMS is full of smells. And their visual, their sensory clues as to what's going on with your patient. If you walk into a nursing home, you can usually tell that the patient, that there is a potential patient with a UTI, or maybe even a GI bleed. Those are very distinct smells, and you can pretty much tell what they are. So we're going to assess the mental status. And how we do that is we use the acronym AVPU, or mnemonic, I guess, AVPU. With AVPU, it's alert for the A, person, place, and time. V is for verbal, and they have a verbal response. A P is for painful response, and U is for the unresponsive patient. Okay. So my patient may be alert, And I know that by them just looking at me when I walk into the room, acknowledging my presence in the room, can tell me that my patient is alert. If I have to talk to my patient to get them to give me some type of response, then that's a verbal. If I have to give them some type of sternal rub or some type of painful stimuli to get them to respond, then that's that painful response. And if they do nothing after I've given them some type of painful response, then they're unresponsive. So the order of the primary assessment will vary depending on the patient's condition. We're going to identify and correct any life threats, gather information that will later help you in your assessment. So, assess the ABCs. We're going to look for signs of life, including movement, scan the chest for signs of breathing. If there's no signs of life, such as breathing, then we're going to check for a pulse. If we don't have a pulse, then we're going to start CPR. So airway, if the patient is alert and talking clearly or crying loudly, then the airway is open. Okay, crying baby is a happy paramedic. I fully believe that. I fully embrace that because I want my patient to be able to cry or speak to me because I know that they have an airway open. Okay, if the airway is not open or is endangered, we want to take measures to open it. Placing an oral airway, just a simple maneuver as opening the airway with a head tilt chin lift or jaw thrust, and then maintaining that open airway. Okay. So situations calling for breathing assistance if the patient is in respiratory arrest with a pulse, not alert with an inadequate breathing. Remember that gasping, agonal respirations, it's not adequate. It's not good enough to sustain life. Okay. Has some level of alertness with inadequate breathing. So again, if they even have like a painful stimuli with inadequate breathing, we need to start breathing for them or helping them to breathe. They have adequate breathing, but signs suggesting respiratory distress, such as hypoxia. Again, we're going to try and fix that. We need to fix those things before we can fix anything else. Okay? So, circulation. Assessing skin. So, this is something that everybody tends to forget. So, good circulation is warm, pink, and dry. That's the standard. You and I sitting here would be classified as warm, pink, and dry. We're not sweaty, we're not pale, we're not blue, and we're not cold or hot. We're warm, pink, and dry. Shock is a sign of poor circulation, and the patient is going to be pale, clammy, cool, and moist. So just be aware of that, especially that little phrase there, that pale, cool, clammy skin. That's where you want to really consider shock. Okay. So checking for a pulse no longer than 10 seconds at the neck. Okay. Is how we're going to assess circulation. So we get 3 results of assessing pulse. You either get within normal limits, unusually slow, or unusually fast. So remember back to chapter 5 in medical terminology, unusually slow heartbeats are bradycardia, and unusually fast heart rates are tachycardic. Okay. And then we're going to check N4 and control any severe bleeding. Okay. So to determine our priority, we're going to treat any life-threatening ABC problems as soon as it's discovered. such as, if they need an airway, we're going to place an airway. We're going to open their airway. If they're not breathing or their breathing is inadequate, then we're going to start breathing for them. If they have a circulation problem, we're going to fix that by providing CPR. So we need to fix those things. Circulation also has bleeding in it, so we're going to fix the bleeding. To be stable, a patient needs to have vital signs that are in the normal range or just slightly abnormal. Okay, so me sitting here, my blood pressure is abnormal. I'll just tell you that right now. I do not have a normal blood pressure. My blood pressure is typically high. So, am I stable? Yeah, I'm stable enough. But in an unstable patient, you're looking at anything that rules out or has a threat to the airway, breathing, or circulation, either actual or imminent. So those are unstable patients. Okay. So if there's no pulse, begin CPR. There's many times when it's not crystal clear that a patient problem is what a patient's problem is. So there's going to be many possible diagnoses, some more serious than others. And a patient's priority can change. Okay. Always remember, always assess your airway, always assess breathing, continually assess those things because they can change in a minute or less. Okay. Then we're going to initiate priority transport if a life-threatening problem cannot be controlled or threatens to reoccur. We're going to continue our assessment and care en route. All right. So why must you continue to reevaluate the primary assessment? Think about it. Our primary assessment is the very first thing that we do. Okay. One of the first things that we do. So when we continually reevaluate the primary assessment, we're continually reevaluating their ABCs. And we're continually reevaluating the need for an airway, the need for the patient to have breathing assistance or CPR. Okay. So how might normal findings in a primary assessment differ for a child compared with an adult? Okay. So we learned back in lifespan development that children are different. Their vital signs are different. Their normal vital signs are different. My 3-year-old has different vital signs than I do. Her heart rate is a little bit faster. Her breathing rate is a little bit faster. So just be prepared and think about those things when you are assessing a child. And we'll get into that more later on when we talk about pediatrics as well. Okay. So chapter review. The primary assessment is a systematic approach to quickly finding and treating immediate life threats. Again, those ABCs, got to fix those things first. Very first thing that we do is to fix those things. The general impression, although subjective, can provide extremely useful information regarding the urgency of a patient's condition. Again, it's done within the first 30 to 40 seconds. This whole thing can be done within the first 30 to 40 seconds if you don't have to fix anything. If your patient's alert and oriented and they're breathing just fine, then hey, great. I've just checked off half of my list, half of my assessment list by just looking at the patient and seeing them. Okay. Here is a suggestion. I can't back up for some reason, but here's a suggestion on general impressions. I know right now we're not supposed to get out, but if you were to go to like Walmart or go to some place with crowds of people, then what you could do is you could people watch, okay, and just get a general impression of those people. When you go out, form a general impression on every single person. Now, your environment is going to be a little bit different, but you can sometimes tell what kind of environment they come from based on how they are. And I know, don't judge a book by its cover, but sometimes you can. Okay, so look at your patients. Do they have any medical gear on them? Do they have any, or when you go out, look at these people and determine, do they have any medical gear on them? Do they have like the compression socks on? Do they walk with a cane? Do they walk with a wheelchair? Or do they ride in a wheelchair? Do they walk with a walker? Do they have oxygen on? Do they have some type of external like device in a carrying bag? You know, those things. Look at those things, determine those things, and just do a general impression of everybody that you see. Okay? Once you've been in EMS for a while, you start to do that with everything that you do. So you form a general impression on everybody that you meet. It's just a bad side effect, I guess. Okay, so moving on. The determination of mental status follows the AVPU approach, the alert, verbal, painful stimuli, or unresponsive. We're going to evaluate the airway, breathing, and circulation quickly but thoroughly. And this will reveal immediate life threats to the patient that must be treated before any kind of further assessment can be done. Okay. Your approach to a patient will vary depending on how he presents. The AHA recommends CAB approach for a patient who appears lifeless and apparently are not breathing or have only agonal respirations. And this will begin with a pulse check and chest compressions if there's no pulse. Okay. If your patient shows signs of life and is breathing, you'll take you'll take the traditional ABC approach. Remember the mnemonic. ABC is a guide to interventions that may be taken. You will choose your interventions based on the patient's needs. The patient's priority describes how urgent the patient's need to be transported is and how to conduct the rest of your assessment. I didn't go into it before, but your priority is what does this patient need to be transported right away, or can we take the time to do a little bit more assessment? Is this a load and go patient or a stay and play patient? Remember that to determine if a patient is responsive or unresponsive, whether the patient is an adult, child, or infant. Rapidly identify the need for immediate airway intervention. Determine if the patient's condition is stable enough to allow further assessment and treatment at the scene. So some questions to think about as we get done and wrap up. What factors will you take into account in forming a general impression of the patient? How should you assess a patient's mental status with regard to the AVPU levels of responsiveness? How should you assess airway, breathing, and circulation during the primary assessment? And what is meant by the term priority decision? All right, so your scenario. You have a middle-aged male who is lying on the street after being hit by a car. He appears unresponsive as you approach. You notice that he is bleeding from a laceration on his forearm and making gurgling sounds from his airway. So if we're alone with this patient, gurgling sounds in the airway require immediate suctioning, unless that bleeding is life-threatening, such as like an artery or something like that. Otherwise, that airway needs to be taken care of first. Okay, so we've got to suction that airway. All right, so if you have any questions, let me know in the discussion below, or text me, call me, email me, anything like that. So, and I will see you in the next lecture.